Hello. A very good morning to everybody. At the outset, I would like to thank Dr. Amar Pujari, who's the chief author, along with my co-authors, Dr. Sujit and Dr. Rajeshwari. And I would also like to thank AIOS Scientific Committee for giving me this opportunity. So my topic is extraocular muscle anatomy teachings for ophthalmic residents on goat's eye. The purpose was to demonstrate the possibility of extraocular muscle anatomy on goat's eye, which we've intended to mimic like a human eye. The method was that initially what we did was inspected the integrity, clarity, and residual extraocular muscles of the goat's eye. Then we found eyes with more than 15 millimeters of extraocular muscles, and from there we initially explored the insertions where a maximum of 3 recti and superior oblique muscle seemed like that of human eyes. And to supplement the inferior oblique muscle and the missing recti muscles, the residual muscle stumps were harvested from the other eyes. For example, coming to the picture on the left side, here you can see that normally inserted muscle is there in the goat's eye. It's kind of replicating that of a recti. We have placed 4-0 silk sutures at the free end in order to mimic normal muscle tension. In the center image, there we can appreciate that there are 4 muscles. The image on the muscle on the extreme left, it's the inferior rectus muscle. The muscle which is evident on the top is the lateral rectus, and just underneath it lies the inferior oblique muscle, which is coursing along the globe. And superiorly, in the most right aspect, we can appreciate that there is superior rectus muscle. The picture on the extreme right has 2 muscles. The muscle which has been hooked upwards is the superior rectus muscle, and the muscle which has been retracted downwards is the superior oblique muscle. In this way, we have managed to demonstrate all 4 recti muscles and 2 oblique muscles on 10 different occasions successfully. The Teenan's muscle relation, muscle insertion, and their anatomical orientation were reliably taught. In addition, simple surgeries like recession, resection, and plications were also demonstrated. And even we were able to demonstrate complex strabismus surgeries like Knapp's procedure in the later on trials. So this is a photograph where we are trying to demonstrate resection of the muscle. We have placed 2 muscle hooks, and then we have resected the muscle. Here we are trying to do a recession of the extraocular muscle. So first you can see on the image on the top left that the muscle is normally inserted. However, in the image in the top bottom right, the muscle has been recessed. We have also tried doing wide splitting of muscles and even done partial nishida. So coming to the conclusion, on goat's eye, all the extraocular muscle anatomies can be successfully simulated on par with human eyes for residents training. We have also published these teachings. Yeah, thank you.
Yes. Did you fix the muscles, and did you note that upper and lower side of this? Once
Yes,
you
sir.
start resecting, the eyeball will be rotated, and you will not know. The students, of course, don't know that is taken.
So while performing that, first we usually use the gauge pieces, rotate it, and fix the eyeball. The goat's eye, we have fixed it using multiple layers of gauge pieces so that it doesn't move, and fixed it within the cadaver. The mannequin which is used for performing phaco-emulsification simulations were used. We have fixed the eyeballs. We're using gauge pieces, and then using the extraocular muscles, we are able to demonstrate it very clearly. The students were very happy with the results.
Once demonstrated, could you mark it with the ink so that it will not be formed?
Yes, sir, we did actually. Unfortunately, we don't have images of that. Like I had videos of that, so which I don't have.
Have you tried resecting and recessing and suturing also?
Yes, sir.
Or it is what just demonstration of the muscles?
No, we have done resection as well as plication as well. Even tucking we have performed.
So what difference you felt from human eyes?
So the thing is that the exact tension which we feel while performing a strabismus surgery on human beings cannot be replicated. But then again, to some extent, we are able to demonstrate the anatomy which happens, like the changes which happens during the time of surgery. So it gives a better understanding for the students. But then again, it may not be excellent for the surgeon himself.
It's good learning tool. Nice. Good
Thank you, sir.
Any questions from any audience? You may proceed.
Thank you. We have a video, but it's not allowed in the podium.
Demonstrating resection and
Yeah,
recession.
we have it. I have it.
That
with me,
would have
but-
been much better.
Thank you, sir.
May I clarify one thing, that we have 5 minutes for each candidate, 3 minutes presentation or 4 minutes presentation, then the time for question answers will be less. But it will not be injustice to anybody presenting up to 4 minutes. Will you call next person?
I will call upon the next presenter, Dr. Ankita. Sorry, Dr. Punita Kumari Sodhi. Her topic is quantitative retinochoroidal vasculature in Indians with OCT angiography.
Thank
A pencil.
you.
Honorable Chairpersons and my dear friends, I am presenting on quantitative retinochoroidal vasculature in Indians with optical coherence tomography angiography. The retina is probably the most vascularized tissue of the body, and it's extremely important to find the vasculature of retina and choroid to detect various ocular diseases and find causes of non-recovery of vision. The foveal avascular zone is a round capillary-free area surrounded by single-layered parafoveal capillary arcade, and disruption of this causes a reduction in the phase circularity index, which takes place even before the increase of the phase area. Hence, phase circularity index is more sensitive indicator. Additionally, these also correlate with the retinal nerve fiber loss and visual field loss. The data on the phase parameters and the vessel density is not available in the normal Indian population, and choroid is a relatively unexplored area. The aim of the study was to evaluate foveal avascular zone and retinochoroidal vessel density using optical coherence tomography angiography in normal Indians. The study was approved by the Institutional Ethical Committee and informed consent was obtained from all participants. Done at Department of Ophthalmology, Guru Nanak Eye Center in 200 eyes of 100 normal Indians having mean age of 32 years and best corrected visual acuity of 6/6 and refractive error not more than 1 diopter on a Octa Nidec advanced to model in 3 mm to 3 mm scans. The mean phase area was found to be 0.5 mm square, 0.4 mm square. Phase perimeter was 3.3 mm, and mean circularity index was 0.4. The phase area in the normal eyes was surrounded by intact vascular arcade without any gaps or holes, with a vertical and horizontal oval symmetrical formation. The vessel density was measured in the 3 layers. Center circle was 0.5 mm, the middle was 0.5 to 1.5 mm in diameter, and the outer was 1.5 to 3 mm. And the readings were averaged to give whole values. The whole values in superficially capillary plexus was 23. Vessel density in deep capillary plexus was 16. In outer retina was 13. In outer retinal choriocapillaries was 39. In choriocapillaries 37, and in choroid 37. When the various studies from other literature were compared for normal values, it was found that our subject had got larger phase area and larger phase perimeter than other population groups studied by other authors, and more values for choriocapillaries and choroid vasculature, whereas values for superficially capillary plexus and deep capillary plexus were lesser than the other studies. And in our case, among the 6 layers, outer retinal choriocapillaries was the highest vascularity, and the outer retina was having the lowest vascularity. When the correlation was done with various parameters, it was found that the thicker central foveal thickness was associated with higher vascularity in superficial capillary plexus, deep capillary plexus, and outer retina. And thicker for choroidal thickness was associated with increased vascular density in all the layers except outer retina. And as the vascularity of outer retinal choriocapillaries improved, the values of visual acuity also improved. Age in our study did not have any correlation with other parameters. We did not correlate our octa parameters with refractive error and axial length and gender. So we conclude that qualitative grading of phase is not standardized because we do not have standard fundus landmarks. So we should have quantitative value of phase and vascular density in normal Indian population to help comparing and diagnosing diseases. Thank you.
Your inclusion criteria?
Normal Indian population.
Age group, age, gender.
Mean is 32 years, and gender was 62 males and 38 females.
So does it have any bearing on the findings?
We did not study with
different genders, different age groups.
Yeah, there is one study has told that boys are having more vascularity, but we did not study with respect to genders.
Did you exclude the deceased persons having ocular?
Yeah, only normal Indian population was taken without any ocular and systemic disease.
Any questions from audience? Thank you, madam.
Can I make the next person? I call upon now Dr. Devang Angmu for his paper on virology and cytological changes in tears and conjunctiva of patients with COVID-19.
A very good morning to everyone, faculty on the dais, and to all my colleagues. I would like to thank AIOS and Chief AFP Center for letting us, allowing us with this study. So the title of the study is Evaluation of Coronavirus in Tears and Conjunctival Secretions of Patients who are tested positive with SARS-CoV-19. And to introduce, we have seen that there have been many studies that have shown the presence of SARS-CoV-2 in tear samples and conjunctival swabs, and they have been in various ranges from 0 to 24%. In our study, we wanted not only to analyze tears and conjunctiva for the presence of the virus, we also wanted to see the study accompanying any morphological changes in the conjunctival epithelium and to identify the viral nucleocapsid protein within the epithelial cells immunohistochemically as a means to document active viral replication, a study which has not been done till now. So it was a pilot longitudinal study because it's the first of its kind, and we had taken 40 cases and 10 controls, and ocular samples, that is tear and conjunctival swab collected in the viral transport media was taken. This was the scheme of the study. We had taken COVID positive patients from the ICU, and tears and conjunctival swabs were collected from the eye. And thereafter, they were transferred into the viral transport media and transported to the virology lab for the RT-PCR. And on the other hand, we also prepared smears and transported into screw cap bottles for cytomorphology and immunohistochemistry. So the patients underwent tear and conjunctival sample analysis, which was done at day 1 to 4. The second sample was taken from day 5 to 7, and the third sample was taken day 10 to 14 to see any tear and conjunctival swab for RNA isolation, and also to see the conjunctival cytology that we had studied. So for conjunctival swabs, we had used the conjunctival flock swab rather than the Schirmer's strip, and these swabs are much superior in detection for the same. So coming to the results, we had enrolled a total of 73 consecutive patients. However, out of this, only 41 cases were included for analysis. Patients, because of our inclusion criteria, we had included patients whose respiratory samples were tested positive from our own lab to avoid any other analysis deviation, and we also those tested by CBNAT or any other lab, we excluded all those patients. The median age of the patient was 48 years. The male is to female ratio was 2:1, and 22 patients were classified to have as moderate disease, and 19 patients were having severe disease. Out of this, only one patient reported ocular symptoms, which was a case of bilateral chemosis. And out of the 41 samples that we have tested, the tear swab samples were positive in 6 out of 41, that is approximately 15% of the cases. And 3 conjunctival swabs were also positive, which is around nearly 7%. And these 3 amongst the 6 whose tear swabs were positive. And all our repeat samples, they tested negative for viral RNA. So out of the 41 samples taken, the samples of only 30 patients were adequate for cytological analysis. So in the cytological analysis of the cases, we saw that there was a lot of neutrophils present, nuclear enlargement, binucleation, multinucleation, nuclear membrane irregularities, suspicions of inclusion as it is seen. However, of the controls, we could see that there was no signs of inflammation and they were uniform nuclei. So immunohistochemistry was possible only in 30 cases, and only a single case revealed positivity for SARS-CoV-2 nucleocapsid protein in the squamous epithelial cell, that is the case 10, the figure of which was depicted. And interestingly, the tear and conjunctival swab for RT-PCR assays were positive in this case with severe disease, and this patient had the lowest CT value, indicating that it had a high viral load in the tears as well as conjunctiva. The remaining immunostained smears from patients and controls did not reveal any immunopositivity in any of these cells. We did have a limitation of having a relatively smaller sample size and inadequacy of few samples. In some cases, the follow-up samples could not be collected either due to the death of the patient or transfer or of discharge. So to conclude, the viral RNA was detected in nearly 15% of our patients. The conjunctival smears from patients with COVID-19 revealed cytomorphological alterations even in the absence of clinically significant ocular infection. However, viral proteins were demonstrated within the epithelial cells only rarely, suggesting that while the conjunctival epithelium may be a portal for entry, viral replication is possibly rare or it is very short-lived. Also, the ocular surface secretions can also be a potential source for diagnosis with high specificity, albeit low sensitivity, especially in the early period of the illness. And despite rare ocular manifestations of the illness, the inflammatory alterations indicate that virus does infect the epithelium that can have implications in the long term as a potential for dry eye disease or any form of ocular surface problems. Thank you.
Thank you, Dr. Deva. I just one question, why there was less controls?
Ma'am, controls, ma'am, basically we had taken controls only to see for the how it was relative to the normal. Ma'am, doing all these immunostaining, it is very costly. So if we were like, at least we see in 10 patients and see if, if it's significant. If it is significant, we might recruit more. But in all of the 5 patients that we have seen, nothing was significant. So that's why we couldn't do because of the limitation of the funding.
Okay, thank you.
You have taken sequential swabs.
Yes, sir.
In all of them, all swabs were negative?
Yes, sir.
Or they were dependent on the treatment?
Yes,
different
sir.
Treatment?
Yes, sir. They were on different treatment while they were admitted.
So can you conclude that ocular surface offers better resistance?
So I won't
Why
say...
you could get so less samples positive?
So that
7% and 14%.
Yes, sir. So basically it was 14%, and if you look in the world literature also, the range is, a couple of studies have saying that they have 0%, few studies have ranged from 7 to 14%, and one study has shown only 20%. So the ocular infection is lower as compared to the pulmonary findings that they were positive on the nasal swabs.
Good study.
Did you give any local antiviral treatment other than systemic treatment?
No, sir.
And still took the swabs?
We did not give any local antiviral treatment, only systemic treatment that was going on, and symptomatic treatment. If the patient had some dryness or something, artificial tears were given, otherwise no other treatment was done.
Fine.
Okay.
Any questions from audience? Thank you, madam. Bolo to, sir.
Next speaker invited is Dr. Avdesh Oli. His topic is modified patch test to elicit meso phenomena.
Respected judges and dear colleagues, I will be presenting on a modified patch test to elicit Mizo-Nakamura phenomena. So, we all have heard Oguchi disease is an important differential diagnosis of night blindness, which characteristically presents with the Mizo phenomena, which was described by Japanese, and which is disappearance of yellow sheen of the fundus after dark adaptation. Means the fundus gives a different appearance when it is light adapted and different when it is dark adapted. So for this we require a dark room which is conventionally used to elicit the response. However, in a modern day ophthalmic clinic we have space constraints and it may not always be possible. So we describe a modified patch test to demonstrate Mizo phenomena. Also the metabolic, genetic and multimodal features of a case of night blindness are described, who was initially diagnosed as Oguchi disease based on this phenomena, but genetic testing finally clinched the correct diagnosis. So a young male presented with night blindness for past 10 years. He gave history of alcohol abuse and chronic liver disease. So he was, but he was initially diagnosed as a case of Oguchi disease. And at presentation, his vision was 20/40 in both the eyes. He had dry eye and increased mucous debris. His color vision was normal, pupils were normal, and fundus showed yellowish sheen with flecks. And this is the OCT, which is showing these hyperreflective dots in the outer retina. And in the autofluorescence also, we can see these hyperfluorescent specks in the peripapillary area. So to simulate a dark room and elicit mesophenomena, we patched this patient with conventional cataract surgery patches. And we could elicit this phenomena, as you can appreciate from the photographs, that before patching there is a yellowish sheen of the fundus, which is when it is light adapted, and after it is dark adapted, that yellowish sheen disappears. Similarly, in the other eye, before patching, which is light adapted, and after patching it is dark adapted, and that yellowish sheen disappears. So we went ahead and did the electrophysiology studies. The ERG showed reduced rod function, EOG showed reduced Arden ratio, and we did his vitamin A levels. They were very, very low, less than 1000 times, and his liver function was grossly deranged. As he was earlier labeled as Oguchi disease, so we went ahead with genetic testing for SAG gene mutation. It was negative. And based on the clinical features, he was finally diagnosed as a case of alcoholic liver disease with severe vitamin A deficiency. Vitamin A supplementation improved his symptoms, and this modified patch test was useful to elicit mesophenomena. In this case, we found that vitamin A deficiency could be the cause of mesophenomena because he didn't have Oguchi disease on genetic testing. And OCT changes in vitamin A deficiency need to be carefully looked for, as they are described in the literature. Hyperreflective dots in the outer retina, as evident in this case, might be due to photoreceptor accumulation due to reduced phagocytosis, and clinically they are localized in the outer retina. Genetic testing in this case, in such cases, might help to clinch the correct diagnosis. Further studies may be planned to correlate levels of vitamin A and natural course of this mesophenomena. And this is important because with increasing population at risk of vitamin A deficiency, not because only of malnutrition, but also because of statin use, bariatric surgery, the patch test might help in screening and early diagnosis of such cases. And this modified patch test might also be useful for cases of cone dystrophy and color blindness where dark adaptation is required. Thank you.
Any questions, sir?
So was this a case of adult vitamin A deficiency originally, or it is Oguchi's disease?
Sir, I think to begin with, maybe when the comprehensive history was not taken for alcohol consumption, that time the vitamin A deficiency could have been missed. Because on genetic testing there is no mutation for Oguchi disease. So to begin with, it was a case of vitamin A deficiency, and now definitely because the levels of vitamin A are extremely low, less than 1000 times. And we had another dilemma because the liver is not functioning, so we cannot give enough supplementation of vitamin A to him because it is metabolized through the liver. So in a decompensated liver, that was another dilemma.
So from management point of view, it will matter much?
Sir, from management point of view, because vitamin A deficiency is a modifiable factor, number one. Number two, we have to treat his systemic condition, maybe absolute abstinence from alcohol, and if it is very, very severe, then maybe a transplant or some other gastrointestinal intervention would help.
And for Oguchi's?
For Oguchi's, not much.
Nothing can.
Sir, nothing.
Okay.
Clinically, he didn't have any signs of vitamin A deficiency.
He had severe dry eyes, ma'am.
Dry eyes only.
Yeah, he had.
Thank you.
Thank you.
May I call upon Dr. Sonal Shah, presenting tear film parameters in older dry eye patients, pre and post intense pulsed light therapy. Did you give that? Is ready. Fine. Please proceed.
Your name, please. तिथं नो म्हणा लागेल.
Good morning to all panelists and my colleagues. I will be discussing on tear film parameters in dry eye patients in older age group pre and post intense pulse light therapy. So as an introduction, dry eye disease is a multifactorial ocular surface disease that is characterized by symptoms of discomfort, irritation and visual disturbances. Its prevalence around the world varies from 5% to 34%, which increases significantly with the age. The concept and treatment modalities for dry eye are evolving day by day. In recent years, intense pulse light therapy has gained a lot of attention in dry eye management due to its efficacy. Previous studies has also demonstrated significant reduction in the dry eye signs and symptoms post-IPL therapy. So our aim is to study the tear film parameters in older dry eye patients pre and post intense pulse light therapy. So we have done prospective pilot study which is conducted in Isha Netralaya, Maharashtra, and we have included dry eye patients, especially evaporative dry eye MGD patients and patient sample size of 10. So we have included the dry eye patients, evaporative and MGD patients. The age group of the patients are around 40 to 80 years of age and best corrected visual acuity is more than 0.2 log MR and non-invasive tear breakup time should be less than 10 seconds. We have excluded the patients of any systemic diseases, patients on ocular diseases, patients with a history of ocular surgery less than 6 months and contact lens wearers. In methodology, we have followed a routine ophthalmological examinations which includes refraction, best corrected visual acuity, non-contact tonometry and slit lamp examinations. After that, we have assessed the mammalian gland and tear film assessment by using SBM ocular surface analyzer and for treatment purpose, we have used intense regulated pulse light therapy and we have followed the standard manufacturer protocol. So this SBM evaluates the non-invasive tear breakup time, lipid layer thickness and infrared mammography. For intense regulated pulse light therapy, we have followed the standard protocol which includes, in which we have covered the patient's both eyes with the opaque glasses. After that, a clear conducting gel is applied inferior, medial, lateral aspect of the goggle as per manufacturer's recommendation. And the light pulses were delivered in 4 overlapping periocular zones inferior to the each eye, and the 5th pulse were applied temporally adjacent to the lateral canthus. In results, we have found that the mean age group which we have examined in the patients is around 59.86 years of age, and out of 20 eyes, 17 eyes shows a significant improvement in the lipid layer interferometry grades. We have done the paired T test which has revealed a statistical significant improvement in the non-invasive tear breakup time post-therapy. So in conclusion, we have noted statistical significant improvement in the tear film parameters. However, the difference is not clinically significant. This could be attributed to the small sample size and short nature of data. Thus, long-term study and more treatment session would have helpful to achieve the clinical significance. Thank you.
You said there was some improvement. How long did it last? And how long did you follow?
We did around 3 cycles, sir. Means 0, 15 and 45 days. But we have assessed the data on 68 days, sir. So that is the only, means at that 68 day only we have examined the patient and we have taken the parameters. After that we have not evaluated the patient, sir. So we need that more time and also more amount of patients so that we can give a good results.
As you said, 68 day means 2 months.
2 months.
In between, was patient still better? You couldn't make it out?
No, so we did not include anything. We are not examining.
Sample size?
So 20 eyes of 10 patients.
Good.
You ruled out secondary dry eye.
Secondary dry eye, evaporative dry eye.
Thank you.
Thank you.
Now I call upon Dr. Yash Parmar to present his case on pole-to-pole ocular manifestations of varicella zoster virus reactivation following COVID vaccine.
Good morning, everyone. I'll be presenting some interesting cases on pole-to-pole ocular manifestation of varicella zoster virus following COVID-19 vaccine. So COVID-19 hit India in January. In March we had a lockdown, and in these tough time India emerged as a leader by being the leading vaccine producer. mRNA and adenoviral vaccine in the form of Covishield and Covaxin were produced by India, and the benefits of the vaccine were far more than its side effects. But here we are documenting three interesting cases of varicella zoster virus reactivation following COVID-19 vaccine, differing in presentation and affecting various ocular codes. So this is the case 1, where a 36-year-old female presented to us with right eye diminution of vision since 10 days with associated pain and redness. She had taken the vaccine 2 weeks back, the first dose of Covishield, and she gives history of herpes zoster associated anterior uveitis 1.5 years back. Her visual acuity was 6/18. We can see that there was congestion, there was scleral thinning with the violaceous hue, and there was anterior chamber cells flare also and KPs. A diagnosis of varicella zoster virus associated keratosclerouveitis was made, and she was started on oral steroids along with topical steroids and cycloplegics. She responded well to treatment with resolution of all the symptoms which we can signs and symptoms which we can see in the photographs. This is the confocal analysis, where in the above two images, in this image we can see that there is immature dendritic cells. The nerve fiber layers have got disrupted because of the virus, and this is multiglobular cells, and after treatment the immature cells have become dendritic cells have become mature, and there is resolution of keratic precipitates. This is another case where a 56-year-old female presented to us with a diminution of vision in the left eye since a week. She gives history of having herpes zoster ophthalmicus 2 weeks back, for which she saw a dermatologist and was treated with oral antiviral drugs. On examination, she had keratic precipitates, prominent corneal nerves, anterior chamber cells and flare. She gives history of vaccination 2 months back, and post-vaccination she had fever for a day. After treatment, she was given oral steroids and topical steroids and cycloplegics. She responded very well to treatment with resolution of all her signs. Similar findings of immature dendritic cells and KPs were seen, which resolved on treatment. This is the third case, where we can see that a 52-year-old male presented to us with right eye diminution of vision since 10 days, and the vision was counting finger close to face. There were anterior chamber KP cells, anterior chamber cells, flare, KPs, and posterior segment shows vitritis, retinitis with hemorrhages and disc edema. Confocal analysis shows immature dendritic cells and keratic precipitates. He was started, he visited locally to a doctor, and he was started on oral steroids along with topical steroids and cycloplegics. After starting of oral steroids, the patient worsened, and he presented to us. So PCR analysis was done for all the patients, and it was found to be positive for varicella zoster virus. This patient was given intravitreal ganciclovir along with followed by topical treatments. He was started on oral antiviral drugs, and then the oral steroids were restarted. He responded very well to treatment, but unfortunately again he had a retinal detachment for which he was operated upon, and he did well with a final visual acuity of 6/18. These are a few literature. Most of it is on herpes zoster ophthalmicus and dermat related. There were a few, and the mechanism shown was either due to the cascade of events in immunological events, or there is a selective suppression of immunity which caused the flaring up of VZV. So the emphasis here is in the third case, where the patient was started on oral steroid as he was diagnosed as posterior uveitis. The viral component of it was not suspected, hence there was a flare up of the inflammation. So whenever we see that kind of a picture, a high index of suspicion should be there for viral etiology, and the patient should be started on oral antivirals. So in conclusion, the benefits are far more than the side effects, but a high index of suspicion is necessary. Thank you.
In the third case, there were retinal lesions.
Yes,
but in
sir.
first two cases, you did rule out all the retinal conditions?
Yes, sir.
There were no?
There were no retinal findings, only anterior segment findings.
Was there any other signs of immunosuppression in the patients?
No, sir. Only one patient, the second patient, she was a known case of rheumatoid arthritis and on methotrexate. So that was a confounding factor where she could have had immunosuppression because of that.
And duration after vaccination, was there?
So most of the mean duration was around 1 week. Most of them presented around 1 week, 10 days.
Okay.
Thanks.
Thank you. Excuse me, she has one question.
Just one patient, the same patient who had rheumatoid arthritis, she had got fever for a day after the vaccination. No, none of them had that. No. So there was just 3 patients, so there is actually, it won't do a justice if we put a mean age to it. So one patient was 36, other was 56 female, 36 female, 56 female and 52 male.
Thank you.
Thank you.
Thank you.
Next presenter is Dr. Bindya C. Her topic is transition to subtenance anesthesia in cataract surgery. Has block related complications reduced?
Sir, एक अजून होते जे हे नाही आहेत, not a member.
राहिलं काय?
हाँ, हाँ.
Oh, sorry. Oh, एक मिनिट.
But easy present.
Dr. Chris, hi.
Oh,
Here.
mark resume.
She is not ratified.
The author is not ratified, hence we were not for the award section.
Yes.
Please present your case. Presentation on assessment of cup disc ratio measurements, optic nerve head photograph versus SDOCT.
Good morning. The assessment of cup to disc ratio using a subjective method is one of the most widely used clinical techniques of documentation of the optic nerve head status in patients with glaucoma. And the clinicians generally use the cup to disc ratio to quantify neuronal loss, as this metric correlates with the global field index. This is essential in the monitoring of glaucoma progression. While monitoring the effect of treatment on glaucoma, accurate and reproducible measurements of the disc are necessary, and confocal and optical coherence tomography are quantitative objective methods which can accurately evaluate various parameters of the optic nerve head topography. Clinicians primarily use the OCT to evaluate the changes in the thickness of the retinal nerve fiber layer of glaucoma patients. In addition to this, the OCT also provides information about the optic nerve head, including the horizontal cup to disc ratio and the vertical cup to disc ratio. Several studies have reported that the time domain OCT measurements of these parameters are reproducible and also reliable. The purpose of this study was to assess the degree of agreement between subjective as well as objective methods of the cup to disc ratio estimation using optical coherence tomography and to determine if these measurements correlate. It is important also for us to know if these methods are interchangeable for the treatment of any patient. In the study, 126 eyes of patients attending the ophthalmology clinic from January 2021 to July 2021 were included. 2 general ophthalmologists with the same years of experience independently assessed and arrived at the subjective cup to disc ratio measurement using the fundus photographs. The average of their measurements was taken into consideration. The vertical cup to disc ratio, the horizontal cup to disc ratio were acquired from the OCT scan, and RNFL thickness measurements using RNFL protocol was considered. The average RNFL thickness for normal subjects was taken as 105 plus or minus 38.79 microns. The results of the study: 126 eyes were analyzed in the study and all participants were Indian. The mean age of the participants was 42 years, with 80 being male and 46 being female. The difference between the examiner and the OCT noted cup to disc ratio was divided into categories, with most eyes, 106, falling into the category of having cup to disc ratio between 0.1 to 0.3. And using the Pearson chi-square test, the correlation between subjective and objective methods was calculated, which was 0.946, which showed no statistically significant difference. A majority of the patients fell into the subgroup of having average RNFL thickness of less than 105 microns. And the correlation between average RNFL thickness and the difference between examiner as well as OCT was considered. The p-value of this was less than 0.01, which showed a statistically significant negative correlation. This is a representative case of a 61-year-old patient having a fundus photo examination showing cup-to-disc ratio of 0.4:1 as ascertained by the examiners. The cup-to-disc ratio calculated by the Topcon 3D OCT Mastro was 0.67. Some structural changes in the optic disc morphology during the early stages of the disease precede visual field loss. The early detection of the optic nerve damage along with the follow-up for treatment is crucial for the management of glaucoma. And this study evaluated the relationship between the subjective and the objective approach in estimating CDR ratio in patients with and without glaucoma. The subjective assessment of CDR is limited to high inter- and intra-observer variability, whereas the OCT provides reproducible measurements of the optic nerve head parameters. In this study, the objective methods OCT yielded high estimates of CDR compared to the subjective methods by fundus photo examination. There were no statistically significant differences between the subjective and objective methods of cup-to-disc ratio estimation in the study, similar to those conducted previously. 60% of the eyes had an average RNFL thickness of less than 105 microns, out of which 67 had a difference of less than 0.4 between the subjective and the objective methods. The correlation between the difference in these two methods of assessment of average RNFL thickness was found to be statistically significant negative correlation. So this study demonstrated the agreement between subjective as well as objective methods. The use of the objective methods of cup-to-disc ratio estimation can provide reproducible and accurate measurements. And the study also highlights the importance of clinical examination along with OCT as an aid in the early detection of glaucoma. Thank you.
Did you check the refractive status of all patients?
No, sir. Refractive status was not considered. The examiners were presented with fundus photo images, and they were asked to assess independently the cup-to-disc ratio.
Will it differ in myopes?
Yes, sir. There can be a difference in myopes as
So the
well as
clinical judgment can go wrong.
Of course, sir. Yes, sir.
At one place you mentioned the ratio as 0.4 to 1. So how will you? So is this the correct way of mentioning?
The cup-to-disc ratio was 0.4:1, sir. As ascertained by both the examiners.
But generally we describe it as 0.3, 0.4, 4:1. What is the way we describe cup-to-disc ratio?
The vertical and horizontal cup-to-disc ratio. Yes, sir.
Okay, take.
Thank you, sir.
Thank you. दोन्ही nomenclature आहेत खूप हाय रेशो होता.
We now have Dr. Bindiya C. Presenting her case about transition to subtenance anesthesia in cataract surgery has block related complications reduced.
So today my presentation is about transition to subtenance anesthesia in cataract surgery, whether the block related complication has reduced. So peribulbar anesthesia is the most popular technique used in cataract surgery. It is not completely free from complications. Subtenance anesthesia involves infiltration of local anesthetic agent directly into the subtenance space after instillation of local anesthetic drop in the conjunctiva, which takes away the pain from the needle prick. It is usually given in the infero-nasal quadrant. Material and methods. Inclusion criteria was patients whose cataract surgery was done under peribulbar or subtenance anesthesia. Duration from May 2013 to April 2016, it was peribulbar anesthesia, and then there was a transition, that is from May 2016 to April 2019, it was subtenance anesthesia, and the total duration of the study is 6 years. Study design is a retrospective study analyzing complication rate between peribulbar and subtenance anesthesia, and data was obtained from hospital medical record. Coming to the results, 98,200 surgeries were done under peribulbar anesthesia during pre-transition period, and 1,16,144 cataract surgeries were done under subtenance anesthesia during the post-transition period. So the outcomes taken into comparison were globe perforation, chemosis, subconjunctival hemorrhage, number of repeat blocks, and positive pressure. So we used the proportion test to analyze the results, and it was found that perforation rate was almost like 0 in case of subtenance anesthesia compared to peribulbar anesthesia. But there is significant rise of non-serious complications like chemosis, subconjunctival hemorrhage, number of repeats, and positive pressure in case of subtenance anesthesia. So coming to the discussion, majority of the subconjunctival hemorrhage which was in subtenance anesthesia is confined to one quadrant, and it can be prevented by careful dissection of the conjunctiva. It will resolve in 7 to 14 days. Chemosis occurs when anesthetic solution is spread into anterior subtenance space, causing ballooning of conjunctiva. So it can be prevented by introducing anesthetic solution in posterior subtenance space and applying digital pressure for 3 to 5 minutes. It will resolve in about 24 to 36 hours. Globe perforation is the most sight-threatening complication. It has a poor prognosis and there can be need of additional surgeries. So there was a similar study done by Parikshit et al. And it was found that subtenance anesthesia is safe and as effective as peribulbar anesthesia and is more comfortable to the patient at the time of administration. So limitation of the study is definitely it has a less sample size. So coming to the conclusion, in case of subtenance anesthesia, there is almost nil risk of globe perforation. There is a short learning curve. It is less painful for the patients. It is not a blind procedure, and there is avoidance of sharp needle. So thus we conclude that subtenance anesthesia is as effective as peribulbar anesthesia. Thank you. These are my references. Thank you.
Your title is block related complications have they reduced, and now you are saying the conclusion is it is safe.
Sir, it is like non-serious complications, it has increased in case of subtenance, like chemosis, all those subconjunctival hemorrhage and all. But we are more concerned about the serious complications like globe perforation. So I think considering that, definitely subtenance anesthesia is better.
You had tested 98,000 patients in 6 years. It was not given by a single person.
Yes.
So can that vary and will vary the result?
Yes, sir. Definitely based on, because some blocks will be given by residents. So based on the persons who give the block, definitely it can vary and there is a bias.
And why are you telling it is less sample size?
98,000.
Sir, considering all these bias, I consider it little less.
You want more?
Basically duration was 6 years, so I think we could have taken it.
It's a huge task to analyze so many patients. But did you really have details of those who have given the injections?
Sorry, sir. That exactly we had details, but actually I didn't involve it in the study as a parameter.
That was most important. Like sir said, your title could have been better. Another thing is, what about the quantity of drug given in peribulbar block and the subtenance? Even that should matter a lot.
Usually in our institution in subtenance anesthesia we are giving like 3 ml, but in peribulbar anesthesia it can go up to 5 ml, ma'am.
So even that was not mentioned.
Which type of cataract surgery was done?
Ma'am?
Which type of cataract surgery was done?
Mainly it is a small incision cataract surgery, sir.
Have you bifurcated those findings, phaco and?
Yeah, we could have compared that also.
So there were no phaco surgeries involved, only small incision cataract?
No.
Since 2013?
Mostly it is SICS, but phacos are also there.
You're from which place?
Are you asking?
This hospital?
Aravinda Hospital, Pondicherry.
Okay.
Thank you.
Next speaker is Dr. Shruti Deep. Her paper is Evaluation of a Novel Wearable Device for Measurement of Sunlight.
Good morning, everyone. So today I will be talking about evaluation of a novel wearable device that we designed for the measurement of sunlight in children. So we know that childhood myopia is a refractive error that has increased in prevalence recently, and we are almost expecting 50% by the year 2050. That's a staggering 5 billion people. And of course, there's a huge cost that is involved to myopia management, almost $7,000 in Australia and almost $4,000 in China just for the medicine part alone. And we also have a very simple solution to the disease, and that's through sunlight exposure. So the purpose of our study is to find out how well we can utilize sunlight, or what are the factors in sunlight that can provide protection towards the onset and progression of myopia. Now, what we don't know about sunlight is that what is it in sunlight that actually protects. We don't know if it is the UV, the infrared, or the visible part, or whether it is the physical activity, whether it is the heart rate or the ambient temperature. So this device was designed to do that. It has an ambient light sensor on the top, along with heart rate sensors and other I will be talking about. So the light data was programmed to be captured once every minute between 7 a.m. and 7 p.m. and stored. And the validation of the measurements was done by placing the device in sunlight alongside a standard luxometer. So the ambient light sensor gets to measure the light intensity, that is the visible light spectrum, the ultraviolet and the infrared. So what is the data we can harvest? Like I said, the illuminance levels through lux using the ambient light sensor, the UV exposure, the infrared exposure, the physical activity through an accelerometer, heart rate, ambient temperature, and finally the overall outdoors time in minutes. Now, putting all of these parameters together, the overall outdoors time can be calculated. Now, it works through the sensor which receives the data from the sun and then converts the raw value into readable data and stores it in the device. The device can then be synced to the mobile phone application. Every hour, 60 measurements. That means one measurement every minute is recorded. So the mobile phone application looks like this. So this is how the user interface looks, and every date wherever you click you can get a 24-hour plotted graph of how and when exactly the child was outdoors and how much of sunlight he was exposed to. And we can also track the steps and also set goals for how much steps and how much sunlight exposure you want the child to have. Now 8 devices were then tested in 4 different settings, 1 week in outdoor direct sunlight, 1 week in outdoor shade, 1 week indoor near a window, and 1 week under artificial illumination. Now hourly readings from these 8 devices were analyzed, averaged, and they were plotted on a 24-hour graph. So the definition of outdoor time usually is less than 1000 lux. Like outdoor is more than 1000 lux, indoor is less than 1000 lux. But when we see in the results, we have a little bit of a bias. So sometimes indoor readings were less than more than 1000, and outdoor readings were less than 1000. So we put that, or we decided to go more real time and put all the data that we collected into machine learning, and then we tested it using the Python software, 60% in training and 40% in testing. And the difference between indoor and outdoor we measured using real-time data. So this is right now the validation results. We have the standard luxometer against the device, and then we put it on a correlation chart, and we found a correlation coefficient of 0.786. Then what we did with the data that we collected from the 4 settings, we plotted it on a 24-hour graph, and you can see each hour shows one average value. That value basically, for example, if you take the 2 to 3 p.m., which is the 3764, it is from 8 devices for 7 days. So it's roughly an average of 3360 data points. When it comes to the actual readings, the visible light was the brightest. You can see that in the bright sunlight it was 30,000 lux. The minimum was 10.8 lux on this side. The ultraviolet followed the same pattern. It was more reliable than lux as a value of internal to external, and infrared light also followed the same same pattern. So we then went ahead and did machine learning, and we found excellent reliability between indoors and outdoors when we tested the data with a good accuracy of 67%. So now the device is equipped with machine learning to tell us exactly whether the child is indoor or outdoor based on real-time data. So this is again just the results. I've put it out. So to conclude, this prototype provides reliable measurements of sunlight spectrum exposure to the wearer. It is based on real-time machine learning derived thresholds for indoor and outdoor. For the clinician, it is very good to customize myopia control. For the researcher, it is very good as a research tool to find out what it is in sunlight. And also for the parent, it is a very effective tool to monitor and promote outdoor time in their children. And because of the low cost of manufacturing, the device may be affordable when it comes into commercial use. Thank you.
Geographically, where was it conducted?
Sir, it was conducted in Chennai, sir, which is in South India.
Will it differ in different tropical countries and
Yes, sir.
where they don't have sunlight?
Definitely, sir. Actually, we are in the tropical belt, so we are also trying and testing it in other parts, like in the temperate climates, to see whether there is a difference in this, in the way the parameters are measured. So, as you say, there is a chance that the measurements may differ in different regions of the country as well as the world. So, as of now, we have tested it in South India, sir.
Can cloudy atmosphere mask the outdoor time?
Yes, sir. Yes, sir. Cloudy temperatures, especially in the twilight time of the day also, sir, we are finding that in machine learning, we are not able to exactly define if it is indoors and outdoors. But again, what we did realize that more than the definition of what is indoors, outdoors, a cumulative exposure to sunlight value is what we are now looking at, because that is what is more important for the child. So if it is cloudy, the child is anyway not going to get sunlight. So it doesn't matter whether the child is indoor or outdoor. So we are now looking at cumulative sunlight exposure as a way of measuring the exposure to the child.
He's asking to conclude, but one more paper is required. Excuse me. I'm sorry, madam. You are saying to conclude, but one more paper is left. So 4 more minutes? Because it is injustice to the presenter, who is the last one. Right. Thank you, madam.
Thank you, sir.
Thank you, Dr. Shruti. We now invite Dr. Ashna Agarwal to present about retinal fiber layer thickness in patients of migraine and OCT based study.
She present.
Dr. Ashna Agarwal, are you there?
Nahi.
No, it's
Last call for Dr. Ashna Agarwal.
Thank you.
Thank you.
I thank all the presenters presenting in time, and the mark list will be presented to AIOS. Thank you.